We are live.
Good evening, everybody. Welcome you all to another iFocus session. Today we are in the 540th lecture. Currently we are running in the Optics and Refraction module number 15. Today we are going to learn about optical principles, types, visual acuity, optical principles, types, measures and notation by Dr. Lakshmi Kuniyal ma'am. To moderate today's session, we have Dr. Major Srishti Kular. She has done a MBBS MS in DNB. Currently, she's an assistant professor at Military Hospital, Agra. She has various awards and honors at this young age. She has won the first runner-up in iFocus PG National Quiz 2023. She's been the contingent commander of the first ever all-woman matching contingent from the Armed Forces Medical Services in the Republic Day Parade 2024. She has won the Ophthalmic National Heroes of India Award by AIOS 2024. She has stood first in the course ending exam Advanced Course Ophthalmology 2024. She has around 7 international publications and 14 national publications to her name. And she has recently won an International Heroes Award by AIOS 2025. Welcome, Dr. Srishti. And over to you for the introduction of our chairperson and speaker.
Thank you so much for the kind words, ma'am. It's my privilege to welcome you all to today's iFocus session. Let me begin by introducing our distinguished chairperson for the session, Dr. Neeraj Khungar. Sir completed his MBBS and MD from the prestigious All India Institute of Medical Sciences, New Delhi. He is currently serving as a senior consultant at Center for Sight, Ajmer, and is also the president-elect of the Rajasthan Ophthalmology Society. Over the years, he has held several important leadership roles, including chairman of the Scientific Committee of Ajmer Ophthalmology Society and organizing secretary of the ROS conference in 2013. Sir is widely recognized as one of the pioneers of phacoemulsification surgery in Rajasthan. He has shared his expertise as faculty in numerous live surgical workshops in both phaco and SICS and has been a respected speaker and instructor at various ROS conferences. His contributions to academic ophthalmology include scientific papers, surgical videos, and instructional courses presented both at national and international platforms. For his distinguished service in ophthalmology, he was awarded the gold medal by the Governor of Tamil Nadu at the IRSI conference in 2014. We are honored to have you for today's session, sir.
Thank you.
And our esteemed speaker for today is Dr. Lakshmi Kuniyal. Ma'am is an accomplished ophthalmologist with outstanding academic training and a wealth of clinical experience. She completed her MBBS and MS, followed by a retina fellowship at the prestigious Shankar Nrityalaya, Chennai. She further specialized with a fellowship in phaco and IOL at RIO Sitapur and is a proud fellow of the International Council of Ophthalmology, UK. She is currently the director and senior consultant at Aarogyam Health Clinic, Mathura. Over the years, she has held leadership positions at several leading institutions, including senior consultant at CIMS Mathura, head of the department at Nayati Medicity, consultant at IQ Gurugram, and consultant Center for Sight, Safdarjung, New Delhi. Dr. Lakshmi ma'am is actively involved in academic and professional societies as a member of AIOS, DOS, and VIRSI. She has published papers in reputed international journals, contributes as a clinical paper reviewer, and is a regular faculty in webinars and academic platforms where she continues to share her expertise with peers and young ophthalmologists alike. Her journey reflects a deep commitment to advancing ophthalmic care, research, and education. With that, I now hand over the session to you, ma'am, to take the proceedings forward.
Thank you so much, Dr. Srishti, for this kind introduction. So I'll be sharing my slides now. I hope all the slides are visible.
Yes, ma'am.
Yes, ma'am.
Yes, it is visible.
So thank you so much before I start to iFocus for giving this opportunity for the content learning. And I thank you again, Dr. Srishti, for the kind introduction. So for today's topic, for the clinical optics part 3, given to me is the contrast sensitivity and the color vision. So let's first move with the topic of contrast sensitivity. What is contrast? It is defined as a degree of blackness to whiteness of target. Contrast threshold means the smallest amount of contrast which is required to be able to see the target, whereas the contrast sensitivity is the reciprocal of the contrast threshold. Now, what do we understand by contrast sensitivity? It is the ability to perceive slight changes in the luminance between regions which are not separated by definite borders and is just as important as the ability to perceive sharp outlines of relatively small objects. Now, as we were just discussing, that it is very important for us to know the difference between contrast sensitivity versus visual acuity, which is a well-known entity among us. So we talk about the measures. Visual acuity counts the smallest object that can be seen, whereas contrast sensitivity gives person ability to detect luminescence differences. The normal or the common testing charts use visual acuity are Snell's or logMAR, whereas for contrast sensitivity, they are Perry-Robson, Wistic, etc. For visual acuity assessment, we need high contrast because usually we have black letters on white, whereas for contrast sensitivity, it is the low and the varying contrast levels. The real-world relevance is quite limited for visual acuity, but contrast sensitivity definitely stands upper because of the strong relation to real world in terms of driving, night vision, and reading. So can we say that contrast sensitivity is a better assessor? Let's see. Sneller's charts test visual acuity at a very high contrast. Thus, many patients may have a good Sneller's visual acuity, but they may be visually handicapped in real-life situations. The visual acuity drops in the situations with low contrast and the quality of vision is not so good. It provides the information that cannot be obtained from visual acuity, and it is often a better predictor of visual performance than visual acuity. Let's see what do we mean by contrast sensitivity function curve. Contrast sensitivity function or CSF graph, it plots an individual's ability to detect differences in contrast at various levels of spatial frequency, which denotes the fineness of detail seen. The resulting curve on a log scale typically forms an inverted U shape, which peaks at medium spatial frequency and decreases at either end, that is at both the lower and the high frequencies. The x-axis or the horizontal one deals with the spatial frequency, which measures the fineness of the detail in a pattern, and it is represented in cycles per degree on a log scale. Whereas the y-axis or the vertical stands for contrast sensitivity, which is the inverse of the contrast threshold, which is the lowest contrast level a person can detect. So this is how the contrast sensitivity curve looks. On the x-axis, we can see the spatial frequency, and on the y-axis, we have contrast sensitivity. Now let's few points about the characteristic inverted U shape. The peak sensitivity of the curve, it lies at the medium spatial frequency where most people have the highest sensitivity. The limited photoreceptors deters the distinction at higher frequencies. Whereas at the lower end, the sensitivity would decrease because it becomes hard to distinguish between broad, low-frequency patterns from the background. Whereas at high spatial frequencies, again, as a spatial frequency increases, the pattern would get finer. Sensitivity would decrease because the details will become too small and difficult to resolve. So how it is measured? As we said, contrast threshold is the lowest contrast level at which a person can detect a grating at a specific spatial frequency, whereas the contrast sensitivity is determined by making it invert, that is 1 by threshold, to get the contrast sensitivity. So whenever we basically measure the contrast threshold, then we calculate the contrast sensitivity, and then we plot it on to get the CSF curve. These are the formulas which helps us to determine the contrast. So we have Michelson contrast formula and we have Weber contrast. Michelson contrast is used whenever we are evaluating the contrast within a pattern like a grating, whereas the Weber contrast is used when the target is viewed against a uniform or defined background. So where these formulas, they carry the importance, they're basically used in contrast dose calculation in CT scans. Then one more terminology comes, that is the modulation transfer function. Now, it measures an optical system ability to reproduce contrast from an object to its image at various levels of detail. Higher the MTF, it indicates better performance and less loss of detail. An MTF curve is a graph that plots this contrast transfer versus spatial frequency, showing how much contrast remains as the features in the image become smaller and harder to resolve. So where the importance of this MTF curve lies, it helps in image quality assessment, system design and optimization, comparison of systems, or diagnosing system flaws, etc. So the curve of the MTF would look like this. So here on the x-axis, we'll have the spatial frequency, and on the y, it will be contrast. Whereas in case of a curve, as I told you before, Contrast sensitivity curve. On the y-axis, you have contrast sensitivity. So this is the difference between these two curves. This contrast sensitivity curve will be dealing with the human visual system, whereas your MTF is basically used for image quality or for the system design optimization. What are gratings? Now, gratings, they are the one adjacent pair of light and dark bars, which makes up one cycle. The thickness of the grating is described by the spatial frequency in cycles per degree of the visual angle at the eye. Large number of gratings can fit within degree of visual angle. We have two types of grating. One is the sine wave grating. Now, these gratings, they lack in sharp borders. So they'll be sinusoidal gratings they used because they're not subject to defocus, aberration, or light scatter. Only the contrast and the spatial positions they get affected. Second, we have the square wave gratings. The square wave gratings, they will have a characteristic like a square, such as sharp edges. We have two types or two aspects of contrast sensitivity. One we call as a spatial contrast sensitivity, and other is a temporal contrast sensitivity. Now, what is spatial contrast sensitivity? This detection of striped pattern at various levels of contrast and spatial frequency. The sine wave gratings of parallel light and dark bands are used, and they're measured with stationary gratings. Width of the bar defines the spatial frequency. Higher the spatial frequency, narrow means bars, and lower the spatial frequency means wider are the bars. As this frequency increases exponentially from left to right, the contrast will also vary logarithmically from 100% at the bottom, and as you move, it becomes 0.5% at the top. Whereas in temporal contrast sensitivity, it is measured with gratings that reverse contrast at various rates over time. So here the contrast sensitivity function is generated for the time related processing in the visual system by presenting a uniform target field modulated sinusoidal in time. So what is the clinical importance of these contrast sensitivity systems? Age and disease can affect both type of contrast sensitivity, but optical issues, they affect only the spatial contrast sensitivity like the lens scatter or the refractive defocus. Let's see how the contrast sensitivity pathway works. So let's break it into step by step. So in the step one, we'll have the retinal processing. So at the level of photoreceptors, that is rod and cones. So rods, we know that they have a high sensitivity to low light or the scotopic vision. They're important for low spatial frequency contrast. That means they help you to see large objects in dim light. They are not responsible for any color information. Whereas cones, they're active in bright light or responsible for photopic vision. They're responsible for fine detail and color contrast. And we know that we have three types of cone systems. Then the vision, after this, the neural signals will be passed on to the bipolar cells. They will collect the signals from the photoreceptors and they will create centers around receptive fields, which are important for detecting the edges. We have on-center, off-surround cells and vice versa. So when we have on-center cell activated, that means that they activated when the center is brighter than the surround. And off-center cell means when the activated when center is darker as compared to the surrounding area. Now, what is the purpose of this on-center and off-center surround cells? Now, this arrangement would amplify the differences in luminescence, will make edges and contrast more visible. Then comes the ganglion cells. Now, we have two main pathways in the ganglion cell pathway which carry the contrast information. We have P cells or the parvocellular. We have M cells or it's the magnocellular. Now, parvocellular ones, they basically the small ganglion cells and they have a role in high spatial frequency, which help to give the fine details and the color. So thus helping in detecting sharp edges and patterns. Whereas the M or the magnocellular cells, they deal with the large ganglion cells and they will help in low spatial frequency, that means motion and broad outlines. And they will ultimately help you to detect moving or large objects in dim light. From there, the signals would move on to the optic nerve and optic chiasma. So signals from ganglion cells, now they will travel by the optic nerve, and at the optic chiasma, the nasal fibers would cross to the opposite side, which will help in the binocular visual processing. The importance of this is here because you have the combination of input from both the eyes, which will improve in the detection of the faint contrast differences. Then comes the role of lateral geniculate nucleus and thalamus. So LGN has 6 layers. The magnocellular layer, that is the 1 and 2, they will process motion and low frequency contrast. Whereas the power seller layers from 3 to 6, they will help to process high frequency contrast and color. So this will actually act as a relay station, which will refine the signals before they reach the cortex. In step 4, the primary visual cortex of the V1 will have its role. Now, it is located in the occipital lobe. It contains orientation-specific columns of neurons, which will help to detect edges, bars, and patterns at specific spatial frequencies. They will integrate the signals from both the eyes for depth and shape recognition. The spatial frequency coding will help for the low spatial frequency neurons. They will respond to coarse and blurry patterns, whereas the high spatial frequency neurons will help to respond to fine and sharper details. From here, it will move to the higher visual areas of V2, V3, and V4. V2 and V3, it helps to further refine the shape and the texture recognition, and V4 will play important role for integrating color and contrast for object recognition. So after we have seen that how this contrast sensitivity pathway is working, let's move on to the theories involved in contrast processing. The first theory we have is the spatial frequency theory, which was proposed by Campbell and Robson. It states that the visual system acts like a set of filters, which is each tuned to specific spatial frequencies. Higher one helps you to get the fine details, for example, letters. Low frequency would help you to get overall shapes and outlines. And the sum of responses from all the filters will give a contrast sensitivity function. The second theory we have, we call it as a lateral inhibition theory. It explains the neural processing of contrast in the retina. Retinal ganglion cells, they are organized in a center surround arrangement. When light hits the center, it would excite the cell. When the light would hit the surround, it would inhibit the cell. And this mechanism would enhance the edges. It would improve the detection of contrast between adjacent areas. Then comes the channel theory. Now, contrast sensitivity function is a function of several independent parallel detecting mechanisms. Now, each channel is highly sensitive to some particular spatial frequency. The visual world is broken into separate spatial frequency components, and this information is then passed on to separate channels to the cortex, where it gets reconstructed. Now, moving on to the clinical part. If the patient has a reduced contrast sensitivity, what are the symptoms we can expect from the patients? The patient may complain having problems with night driving, which may include inability to see the traffic lights. Patient may complain that he may require extra light to read. Their eyes may become tired when they read or watch television, or they may not be able to see spots on clothes, counters, or dishes, or etc. We usually have three variables when we talk about in the measurement of contrast sensitivity. We want to know the average amount of light reflected depends upon the illumination of paper and darkness of ink, degree of blackness in relation to white background, that is contrast, and the distance between the grating periods of cycles per degree of visual angle. What are the methods we have currently with us to measure the contrast sensitivity in our patients? The commonest being Pelly-Robson contrast sensitivity chart. It is checked at a distance of 1 meter. Illumination of chart is 85 candles per millimeter square. Same size letters with the reducing contrast are seen. Each row has got 6 letters organized into triplets of varying contrast. So we here see they are triplets. They are arranged in the form of a triplets. And how the scoring is done? The faintest triplet is recognized and the corresponding scoring would be given to the patient. Like suppose if the patient is able to read up to ZVR, so we'll see ZVR stands for 0.5, so that would be the scoring system for the patient. Then we have Cambridge low contrast gratings. It is carried out at a distance of 6 meters. We have 12 pairs of plates with varying contrast of stripes. The first plate is for demo and the rest are the test plates. The plates are changed sequentially starting from plate 1 till the patient fails to respond. And then a new series is begun starting 4 plates prior to where the patient failed to respond. 4 such series are completed and the score of each series is noted and added. The final total value is converted into contrast sensitivity from the provided table. We also have Bailey-Lowy chart, which helps in detecting low contrast activity testing and in the presence of glare. We have a fixed number of letters in this with a constant spacing in between the letters and the rows. Then comes the functional acuity contrast testing or FAT. Chart with sine wave ratings of varying frequency. It helps to see contrast decrease. In this chart, the contrast decrease from left to right in rows. The spatial frequencies increase from top to bottom in the columns, and the test is carried out at a distance of 10 feet. Patient determines the last grating seen from A to E, and the last correct grating seen for each spatial frequency is plotted on the contrast sensitivity curve. Arden Place test was introduced in 1978, which consists of a booklet containing several sine wave grating patterns, and each grating is oriented vertically. The contrast varies from top to the bottom of the grating, and it is lowest at the top and highest at the bottom. We also have Vistec contrast sensitivity test. Now, these charts again consist of sine wave gratings, and chart contains 5 rows and 9 columns of circular photographic plates on a gray background. Each row has different spatial frequency, and contrast within the row reduces from left to right. The gratings are presented in 3 orientations: vertical, 15-degree clockwise, or anti-clockwise. We also have Regan low contrast test, which consists of 3 letter charts printed on white cardboard, having contrast of 97%, 7%, and 4%. It is conducted at 3 meters with 8 letters in each line. Patients are instructed to start at the top and to continue reading until they can correctly identify no letters on a line. For one chart, letter size goes on reducing and contrast remains constant. Then we have CSV 1000. Now, it is widely used in the world, and this test provides 4 rows of sine wave gratings. Test distance is 2.5 meters for these gratings, for the spatial frequencies of 3, 7, 12, and 18 cycles per degree, and it is good for evaluation of eye diseases. Now, gone through with a huge list of contrast sensitivity tests, let's see in a nutshell that the important test which we have in our hand. The commonest being, as we said, is the Pelly-Robson chart. It helps you to see rows of large letters in decreasing contrast, and it is good because it is quick, simple, and it tests for distance. The Vistec contrast test, it uses sine wave gratings with varying spatial frequency in contrast, and helps you to produce a contrast sensitivity curve. Whereas CSV 1000, it has circular patches with different frequencies and contrast levels, and is commonly used in research and clinical trials. Whereas Cambridge low contrast gratings, it has striped patterns of varying contrast, and it is easy for pediatric or low literacy patients. Whereas FACT, or the functional acuity contrast test, is similar to Vistec but with more contrast steps, and is used in sports vision and driving assessment. So we have gone through all the pathways, we have gone through all the tests which we have in our armamentarium to conduct contrast sensitivity in patients. Now, why we are doing all these things and why the contrast sensitivity is important in clinical situations? So let's see. We have certain clinical conditions where contrast sensitivity errs above the visual acuity in detecting the disease earlier if we just compare it with the visual acuity. So first being the cataract. Now, in patients who are suffering from cataract, they will have decreased contrast sensitivity at low and medium spatial frequencies even before the visual acuity drops. That's quite important. Patients, if they're suffering from glaucoma, they will again have reduced contrast sensitivity, especially at high spatial frequencies before the noticeable field loss occurs. In patients suffering from diabetic retinopathy, they will have early decline in contrast sensitivity even before the visible fundus changes occur. In patients with AMD, they will again have loss of contrast sensitivity more in the central vision region. Patients with optic neuritis or multiple sclerosis, they will show marked drop in contrast sensitivity, especially for low contrast targets. Post-refractive surgery, patient again may show the drop in the contrast sensitivity in the post-operative period. So what is the practical importance of testing contrast sensitivity? Why do we need it in the real world evidence? We want patient to have good contrast sensitivity because we want patient to drive safely. If patient has low contrast, they will have difficult detecting pedestrians at night or reading road signs in fog. So often it is used in driver licensing standards. It is important for sports vision. Athletes with high contrast sensitivity, they perform much better in fast moving games like cricket or tennis. As you've seen, that contrast sensitivity helps in early disease detection like cataract, glaucoma, diabetic retinopathy, optic nerve diseases, even before the visual acuity drops down or the changes come. It also helps us to plan for the low vision rehabilitation. It helps in selecting the contrast enhancing devices like filters or special glasses. So this was all about the contrast sensitivity. Now moving on to the second part of the presentation, that is the color vision. Now, what is color? Color sense is the ability of the eye to discriminate between colors excited by light of different wavelengths. This is a very, I think, famous chart which everybody knows. It shows the function of cones. In human eyes, they perceive color with wavelengths ranging from 400 to 700 nanometers. If it is less than 400 nanometers, we say UV rays. If it is more than 700 nanometers, it is infrared. And both of these, they're invisible to the human eye. Colors, they are formed due to the mixtures of the basic colors, basic or primary colors, that is a red, blue, and green. Colors are appreciated because of the difference in the wavelength of light. Though when we talk about the primary and the complementary colors, the complementary colors, they are basically formed by the mixing of the primary colors, though it's not that as simple in the human eye that you just mix the colors and the complementary color will occur. We'll see in the later slide that how that complementary color is there in the human eye. So when a beam of light, it passes through the prism, it splits into different colors due to the different wavelength of light. So we see when a white light is passing through a prism, it splits itself beautifully into vibgyor. If we talk about the types of the vision system, we have achromatic and we have a chromatic type. So in the achromatic, it will be a black or white. In the chromatic system, depending upon which cone has stimulated, it may be a red, green or blue, yellow type. So as we have said that we have primary colors, and we have complementary colors. So the primary colors being the red, blue, and green, and complementary colors depending upon which cone has stimulated and depending upon the wavelength which is finally being produced, we may have blue, yellow, green, red, or white. So as we have seen that how the contrast sensitivity function was in the step by step. So let's see how the color vision pathway is functioning step by step. So in the step one, the light is being captured by the retina. So when light enters the eye, it passes through cornea, lens, vitreous, and finally hits the retina. In the outer retina, where you have fovea and the surrounding macula, we know that cones are most densely packed in the fovea, which are responsible for providing high visual acuity and color discrimination. Whereas the rods, they are dominant in the periphery and they do not mediate color vision. They only help you to detect the light intensity. If we talk about the cone types, we have three types of cone: S cone, M cones, and L cones. S cones, they have a peak sensitivity at 422 nanometers, which help to perceive blue light. M cones, they have a peak sensitivity at 534 nanometers, help to perceive color of green. L cones have a peak sensitivity at 564 nanometers and help us to perceive red color. The neural signals will then pass on to the bipolar cells and the horizontal cells. So once cones are activated, signals are transmitted to bipolar cells, which will create the center surround receptive fields, which will allow the retina to detect contrast in edges. Horizontal cells will mediate lateral inhibition, which will further sharpen the color contrast. Then comes the role of ganglion cells and the opponent processing. The color information, it is refined through opponent processing, which encodes signals into color contrast pairs. So we have, according to opponent channel theory, the commonest channels which we have are the red-green channel, the blue-yellow channel, or the brightness or the luminance channels. So in the red-green channel, you will have the input between L versus M cones, and the color contrast color received would be red and green. Whereas in case of blue-yellow channels, you will have S cones versus combination of L plus M cones. So here the color contrast would be blue and yellow. In case of a brightest channel, you have a combination response from both the L and M, and it will basically help you to assess the brightness only. So talking about the ganglion cells, here we have three types of cells. We have a parvocellular, we have coniocellular, and we have magnocellular. So parvocellular, they have a small receptive fields. They will help to carry the red-green color and the fine detailed signals. Whereas the coniocellular or K cells, they specialize for blue-yellow processing. The magnocellular cells, they mainly processes luminescence, motion, but not the color. So how clinically it is important? Now, in case of early glaucoma damage, the blue-yellow or the coniocellular cell pathway, it gets defected or gets damaged first, which will lead to the triton defects before the visual acuity drops. After this, in the step 4, these signals would pass on to the optic nerve and optic chiasma. So at the optic chiasma, again, you will have the nasal retinal fibers crossing to the opposite side, but the temporal fibers would remain uncrossed. And this arrangement would allow for binocular integration which is critical for depth and color contrast. At the level of lateral genetic nucleus of the thalamus, the LGN is acting as a relay station and it is separating the signals into the parallel channels. So power cellular is layer 3 to 6. The input would be given by P cells, which will help to see the red-green color or the fine details. The magnocellular or the second layer input given by the M cells will help in the motion and the brightness. Whereas the coniocellular or the interlaminar layers, the input given by K cells will help to assess blue-yellow color. The primary visual cortex, which is located in the occipital lobe, will contain blobs and interlobe regions, where the blobs would specialize for color processing, and the interblobs will help to analyze form, edges, and luminescence. So the processing which happens at the level of V1, it integrates red, green, and blue-yellow opponent signals, and it starts to combine inputs to generate perceived color hues. From there, the signals will reach to the higher cortical areas. In the V2 and V3, we'll have the refinement of color boundaries and figure ground separation, whereas V4 will help in the final perception of color hues, saturation, and constancy. So in conditions where there are damage to the V4, it will result in cerebral achromopsia, where the patient will see the world in shades of gray. So after this, let's see what are the theories for color vision. The commonest being the Young-Helmholtz theory, which says it's a trichromatic color theory. So we have 3 types of cones which deals with different pigments, which correspond to the 3 primary colors, that is the red, green, and blue. The 3 pigments, erythrolabe stands for red, chlorolabe stands for green, cyanolabe stands for blue. So sensation of any color will depend on the relative frequency of impulses reaching the brain from each of these cone systems. In Herring's opponent color theory, it's an extension of trichromatic color theory, which says that we have 4 primary colors. So they have added yellow. So we have blue, green, yellow, and red. So the photochemical substances will give one sensation on breakdown and different on resynthesis. So the complementary colors here will become antagonistic to its respective primary color. Like here, if it's a white plaque, on the breakdown, it shows white, on resynthesis becomes black. In case of red-green, when there is a breakdown, the red will be on and green would get off. On resynthesis, the green will become on and red will become off. Similarly, in case of yellow-blue, when there's a breakdown, yellow will be on and blue will be off. On resynthesis, blue will be on, yellow will be off. The third theory is the Granit's dominator and modulator theory. Now, dominator cells or the Y ganglion cells, they help to detect whole visual spectrum and not the color. Whereas the modulators, they respond to narrow wavelength of light. They're also known as X ganglion cells. They are 3 types. When they respond to from 450 to 470 nanometers, they'll help to detect blue light. For green light, they fall in the range of 520 to 540 nanometers. And for red yellow light, it will be from 500 to 600 nanometers. Now, this theory actually combines both the theories. That is, trichromatic mechanism operates at the receptor level, and the opponent process works at the neural level in the retina and brain for color discrimination. Now, few words about color blindness. Now, we know that color blindness, it can be congenital or it can be acquired. Now, it is congenital. It is due to abnormal gene on the X chromosome. We know females are carriers, and incidence in males 8%, and on females it is 0.4%. When it is acquired, it can be either because of the optic nerve or could be because of the macular pathology. So if we go to the classification of color blindness, we have 3 types. They can be trichromates, they can be dichromates, or they can be monochromates. Now, trichromates means they have weakness for one primary color. So if it is for red color, we can say protonomalous. If it is for green, it's deuter. And if it is for blue color, which is quite rare, it is tritanomalous. Now, dichromates, they cannot appreciate one primary color. So they have got blindness to red, proto, deuter for blindness to green, and trito, that means blindness to blue. So difference between tri and dichromate is that in trichromates, they have a weakness. But in dichromates, they cannot appreciate that one primary color. Now, when the patient has only one cone system, we call them as monochromates, and they see the world in shades of gray. Now coming on to the test for color vision. So what all tests do we have? So we have categorized these tests into the various categories, the first being the plate test. Now, what a plate test? Now, here the observer must identify a colored symbol embedded in a background. So like we see in case of a pseudo-isochromatic plates. So what are the example for these pseudo-isochromatic tests? American Optical Hard-Handy Riddler, or SHARA, the commonly which we use, Devreen, Tokyo Medical College. Now these all tests, they help to provide effective screening about 90 to 95% for the congenital red-green defects. Now here the test would consist of a series of cards on which colored dots of disc of various sizes are printed to form a multicolored figure against a multicolored background. The figure is some easily identifiable letter, maybe numeral or geometric figure. The only systematic difference between the figure and the background dot is in the color. So the figure is composed of dots of one or more colors, and the background is composed of dots of different color or colors. Now the color of the plates appear isochromatic only to the defective observer. So here how the picture of a plate test would look like. The advantage of these plate tests is that they're rapidly and easily administered even by an inexperienced personnel. They're readily available, they're relatively inexpensive, and they can be used on naive subjects, illiterates, and even for children. Now, what are the disadvantages of these tests? Now, the spectral quality of the light source illuminating the plates, they affect the reading of the figures. Success of the plate, it depends mainly on the careful selection of confusion colors. Even when a set of colors is chosen, individual variation in the eye lens and in the coloration of the back of the eye means that a single choice of colors may not be optimal for all the observers. Number of errors on pseudo-isochromatic test tells us little about the type or the extent of a color vision defect. So these tests, they should be primarily used as a screening test to divide people into normal and color defective population because the diagnostic value is limited. The second category, we have the arrangement test. Now here, the observer is required to arrange color samples by similarity in a sequential color series. Now these tests may be designed for evaluation of fine hue discrimination like we find in FM 100 hue test, for evaluation of color confusion like in Franzwell's panel D15 or Lanthony new color test, maybe for evaluation of neutral zones or colors seen as gray, or for evaluation of saturation discrimination. Now, both the panel D15 and 100 tests, they differentiate among protein, deuteron, and tritone defects by the axis along which the confusions are made. So this is the pictorial representation of the arrangement test. Now, what are the advantages? Now, these tests, they are easy to administer and they can be used with naive subjects. The disadvantages means they test require manual dexterity, patience, concentration, and the understanding of abstract ordering. Hence, they are less suitable for young children. The third comes the lantern test. Now, these tests, they were designed as practical means for measuring the ability of seamen, railway personnel, airline pilots to identify and discriminate navigational aids and signals. These tests, they simply require that a system be developed for presenting colored lights to the observer for identification. Now, we have several different models for these tests. Then we Gilles-Archer's, Edinburgh Green, Martin's, and Farnsworth lantern. So this is the pictorial representation for the lantern test. Advantages. Now, definitely it is easy to administer. Now, their value lies in their simulation of the working condition. That is important because you are simulating the work condition for the patient who you are checking. But they do not cannot screen for color defect. Then we have the categories known as anomaloscopes. Here, the observer must manipulate stimulus control knobs to match two different color fields in color and brightness. The anomaloscope is the standard instrument for the diagnosis of color vision defects. The result provided by this instrument will permit the accurate classification of all color deficiencies. Examples, Nagel, Nades, Pickford, Nicholson anomaloscopes, they're commercially available. So here, how this picture looks like. So we'll have the knob where you have to mix and match the colors, the test color and the mixture color here. And you have two knobs, how you have to match for the brightness and for the mixture color, which is given to the patient. Now, these anomaloscopes, they are most difficult to use. Extensive training of the examiner is necessary if they are to be used validly and efficiently. These instruments that is why most oftenly found in research settings. Just to complete this, the treatment options for color blindness, they are the specialized classes, smartphone apps, and you also have gene therapy, which we are targeting for these patients. Now, we have spoken about the pathways. We have spoken about the various tests available with us. Now, again, why they're clinically relevant, why we want to test for the color blindness in the patient. Now, first, because it helps to localize the pathology. Let's see how. If the patient has predominantly red-green defect, it would suggest optic nerve involvement, maybe conditions of optic neuritis, maybe compressive optic neuropathy. If patients have predominantly blue-yellow defect, it suggests retinal diseases, maybe glaucoma, macular degeneration, or diabetic retinopathy. If it's a mixed pattern, maybe advanced disease or a combined pathology. It also helps you to get an idea of the ocular conditions where the patient may present with this color deficiency. Suppose if the patient is suffering from glaucoma, you will have early blue-yellow defect, which may progress to red-green. So it would help you for the early functional loss even before the visual field defect appears. In patients suffering from optic neuritis, you will have a red-green defect, which will help to detect the optic nerve inflammation even before the optic dysphalia sets in. In patients with diabetic retinopathy, there may be a diffuse loss of color vision, no specific color vision loss because of the early retinal dysfunction. In patients who suffer from AMD, you may have blue, yellow, or mixed defect, which will help you to assess the macular function and the progression of the disease. In patients of retinitis pigmentosa, often blue-yellow defect is seen early, which will help in diagnosis and monitoring of hereditary retinal dystrophies. Very important, drug toxicity. Patient who get hydroxychloroquine or who are ethambutol or on digoxin, they show early red-green defect. So it definitely works as a screen tool for drug-induced retinal or optic nerve damage, and it guides us when we're supposed to stop the medicines if that the condition so be. We have seen the ocular conditions where the color vision assessment is helping us, but it also helps us to get the systemic disease association. If the patient has multiple sclerosis, as we said, patient because of optic neuritis will complain for will be assessed for red-green defect. In patients with diabetes mellitus, patient again will show early diffuse loss of color vision because of the retinopathy. Hypertensive patient because of the vascular compromise will again show the color vision defect. Patient with thyroid eye disease may have compressive optic neuropathy, which will err towards a red-green defect. In patient towards chronic kidney disease, because of the metabolic effect on the retina, they may show blue-yellow loss. So besides the ocular condition, it is also helping us to get in systemic disease association too. Now, a few words about the screening in case of the congenital color blindness, that why it is important. It is important because for genetic counseling, because it helps to identify the carriers and affected individuals for family planning. It is important in consanguineous marriages to predict the risk in offspring. It is helpful for school screening because it helps teachers to adapt to educational materials. And sometimes we'll mislabel these children as slow learners. So it will help the teachers to how to deal with these children. And definitely as a career counseling, because we have certain occupations where we require the so-called normal color vision, maybe pilots, drivers, electricians, sailors, military recruits. So that is how the screening for color vision definitely holds an important place. Thank you so much. And that's all from my side for the contrast sensitive and color vision. And thank you all for your patient hearing.
First of all, I must congratulate you and compliment you for such a comprehensive talk and detailed talk. Dr.
Thank you so
Srishti.
much.
Yes, sir. Thank you so much, ma'am, for such an insightful talk on both the topics.
Thank you so much.
Sir, would you like to throw some more light on the topic, sir?
I think she has covered almost everything, but a few details I'd like to add on whatever I know is the first about the lantern test. The lantern test, as you have described, is basically for the railwaymen, pilots and all. So I'll just describe that how that is done basically. There are apertures in this and the size of apertures keep on changing. The examiner keeps on changing the size of aperture to smaller apertures. So that creates a practical situation for a driver or guard if he's driving at a high speed like Rajdhani Express or Vande Bharat Express, and in the fog also they can see the signals or not. So that is how all the driver guards, they are every yearly or 2 yearly, the examination is done for them. And that is a very good tool for early detection for these type of people. About ethambutol toxicity, I like that all the patients who are started on ethambutol, a baseline color vision test, especially for red-green, should be done, because that is the earliest sign. Because before the papillomacular bundle gets damaged and there is a central scotoma, the earliest sign that we can pick up is by the red-green deficiency. So continuous monthly baseline examination, I think our colleagues who are working in chest and TB should be made aware of this, because in my 37 years of experience, I have seen that I have seen a lot of patients of ethambutol toxicity who unfortunately have gone to a stage where the vision is very less. So before they go to such a stage, we should be doing something for them, and awareness to the doctors and awareness to the patients is a must for this. It's a simple test, color vision test, can be done anywhere. As far as contrast sensitivity is concerned, to the younger colleagues who are attending our talks, the usual Snellen chart that you use or you purchase, or the electronically moving charts that we have, instead of that, we should purchase the LED screens that are available by the vendors, like Indian vendors, also easily available. And all those LED screens have this Pelly Robson chart in that. So we should be, if a patient is 6/6, patient is above 40, above 50, and patient complains of poor vision, especially night driving, contrast, and especially in the excessive light conditions, sunlight and all, and you don't find on slit lamp that there is any cataract, we should always do this contrast sensitivity examination on these charts. Dr. Srishti, will you like to add something on this?
Sir, regarding the lantern test, it used to be the gold standard in military also. I'm serving in the army. So we used to practice, or we used to take all the patients who used to fail on the Ishihara chart to a dark room. After acclimatizing them in a dark room for 20 minutes, we used to make them sit at 6 meter distance and make them do Martin lantern test. And based on that only, we used to classify them as CP4 or not fit for joining the army. But now we have evolved to anomalouscope. And so we have shifted from lantern test to anomalouscope for telling that whether the patient is CP pass, that is color vision pass, or fail. So this is the addition that we have done in army. And regarding the contrast test, sir, you just mentioned regarding digital charts, LED charts. So we do have in our OPD also, we follow a digital LED chart for contrast. But there is one doubt that I would like to ask you, sir. It notifies the contrast in percentage. So is that cycle percentage? Could you please throw some light on that, sir?
I'm not aware about the details of this, but and practically when we check it and we see a normal individual and a abnormal individual, definitely the lines as we go down, practically we see that if you can read up to fourth line from top, then your contrast sensitivity is good. But if you are not able to see after first or second line, that means your contrast sensitivity is poor. The percentages and all, I think, were the charts that Dr. Lakshmi has shown. But practically, we don't go into the details of that. We are going into the number of lines from top that you are reading, basically.
Okay. So, Dr. Kritika ma'am, are there any questions for
We
them?
have a question, sir and ma'am, and the question goes as in a patient who is currently on tuberculosis regimen HRZDS taking ethambutol, how frequently should color vision testing be done?
As I said, every month and at the baseline, at the start of the treatment, so that we have a baseline data also, that what is the color vision status of that particular individual. And then it is the red-green deficiency that occurs first, because it is the optic nerve that is involved. It is a sort of optic neuritis. And later on, as the papillomacular bundle is involved, the central scotoma and all are quite late features. So we can pick it up very early and tell our chest and TB friends that they can stop ethambutol as soon as we detect any early damage to the color vision.
Yes, sir.
Like Sir has very rightly pointed out that besides joining hands with the physician, we have to make the patients also aware, because we just not tell the patient that you will have these problems if you're on ethambutol, so that will more concerned to check themselves. So physicians may forget, but patient, if you make the patient aware, they'll be like, no, every month they have to get themselves checked up and they have to ask the physician whether they should stop the drug or not. So for any disease, the patient, they must be, at least for the side effects, they must be made aware whenever you start for these long-term treatments.
Any other question, Dr. Kritika?
So that is all the questions I can see. So that's all questions we have. Very extensively covered topic, ma'am.
Dr. Lakshmi has really done a lot of homework and prepared very well slides. And
Thank you so
thank
much,
you,
sir.
Dr. Lakshmi. In fact, we are also enlightened by your talk. And nice
Thank you,
having
sir.
Dr. Srishti with us, who explained that how Army has gone a step ahead of the railways at the moment.
Thank you, sir.
Thank you. Then I think if there are no more questions, we can call it a day and stop the meeting.
Yes, sir. We can wrap up the session, sir. Thank you so much, sir.
Thank
Good
you.
night, sir.
Thank you, everyone. Bye.
Thank you so
Thank you,
much, sir
ma'am.
and
Thank you,
ma'am.
Srishti.
Thank you so much. Thank you so much.
Good night, everybody.
Good night.